Good afternoon everyone, and thanks to all the organizers and Dr. Bansi Sabu. And my topic is postprandial lipids and diabetes. Let me put my humble suggestion that I am not an endocrinologist or a diabetologist, nor a metabolic physician, nor a lipidologist, and I don't know whether there is anything like postprandial lipidology, but then I am a common man. And I intend to take my topic through the stages of lipid physiology, which is fasting and postprandial stage, because that is the difference, and that is why I have been given this task. And up till now, we have been measuring fasting. All the trials have been the therapeutic perspectives of our knowledge about the postprandial lipids and what's the future. We know that cholesterol and triglycerides, whether they are arrive in the food or in the liver, they have to be transported through the proteins because they are hydrophobic. And it is the lipoproteins which carry or which transport the cholesterol as well as triglycerides. And it is the lipoprotein structure that we have to know for a little, because it is the core which contains the cholesterol or the triglycerides, and the outer core is phospholipids, and there are surface proteins. These are the proteins which identify which kind of apolipoprotein it is, and it also serves as a ligand for the receptors. And we know that the atherogenic lipoproteins are divided basically into atherogenic as well as non-atherogenic lipoproteins. And atherogenic lipoproteins are LDL, VLDL, IDL, and chylomicron remnants, while non-atherogenic is only one, it is HDL. And all HDL is again not anti-atherogenic, some of them are neutral, and that is why NCP and now all the guidelines accept non-HDL as a marker for atherogenic dyslipidemia. And what is important to know from this slide is that it is the triglyceride content of all these different types of cholesterols and fat. Going from chylomicron to HDL, the triglyceride contents go on decreasing while the protein content go on increasing. And cholesterol is highest in HDL and lowest in chylomicron. And what we measure as total cholesterol is a combination of the cholesterols in HDL, LDL, IDL, VLDL, lipoprotein A, and chylomicron as well as remnants. And most of the laboratories measure only total cholesterol, triglycerides, and HDL, and they derive LDL as well as VLDL just by Friedewald formula, which suggests that the LDL is equal to total cholesterol minus HDL minus triglycerides, which is 20% of triglycerides, because that is what is VLDL. So this is valid only for fasting sample, and again it is valid as long as the triglycerides levels are less than 400. But the bulk of total cholesterol is contributed by LDL and HDL, we agree. But the other beta lipoproteins like VLDL, remnants, chylomicrons, transient lipoproteins, they contribute little as long as the fastings are measured in, the cholesterols are measured in fasting state. But the remnants are mostly triglyceride-rich postprandial particles, and they are easy to miss if we measure only the fasting lipid profile. Where do most of us spend our day? Any guess? Wild guess? How much time we spend in the fasting state and how much in the postprandial or fed state? It's almost two-thirds. Two-thirds of the time we spend in the postprandial state, and we talk of only fasting all the time. And when we take 3 meals of 20 to 70 grams, most of the time it is the triglyceride which is yet to come to the level, and then we have another meal. So that is why the postprandial state is a dynamic state, and it has a fluctuating degree of lipemia throughout the day. And what happens in the postprandial state? A lot of talk has been done about the physiology of how the triglycerides and chylomicron enter into the intestine and from there to the liver. What is important is that these cholesterols as well as the triglycerides, when they are brought to lipoprotein to the liver, there are two systems which activate. One is the activation of CETP, which is the cholesterol transport protein, as well as the hepatic lipase. And both of them try to push triglycerides into the HDL and LDL, remove the cholesterol, and that is how the HDL becomes smaller and it is excreted to the kidney, and the LDL becomes smaller and that becomes more atherogenic. So what is the amount of fat required to substantially increase the triglycerides? It is just 30 to 50 gram. and what we are talking is a single stage of fasting. But if we take more, maybe even 20 grams will enhance the lipemia. And we know diabetic dyslipidemia is basically hypertriglyceridemia, high proportion of small dense lipoprotein, low HDL and postprandial lipemia. And even if the cholesterols are same in two persons, one which has a higher triglycerides are definitely having more LDL particles. And that is how the bond of lipotoxicity and insulin resistance. And we know that insulin resistance increases the de novo lipogenesis, increasing microsomal triglyceride transfer protein, and increased intracellular ApoB40 stability. And we have lots of studies to say virtually every aspect of atherosclerosis has been studied and been linked to postprandial, whether it is insulin resistance, whether it is cardiovascular disease or death, whether it is myocardial infarction, ischemic heart disease or death, or whether it is postprandial lipemia associated with coronary artery disease by angiographically proven. Even the first degree of relatives of coronary artery disease people versus normal individuals, the sons of persons with a normal lipid profile or no coronary artery disease have been studied with the sons of people who had angiographically proved CHD, and it has been observed that there is a comparable fasting lipids, but the higher postprandial lipids even at 8, 10 and 12 hours suggest you of delayed clearance of triglycerides. So carotid intima thickness is also linked to postprandial. Remnant cholesterol as a cause of ischemic heart disease has also been proved, and acute hyperglycemia we know is a leukocyte activator, and that leukocyte activator is because of the interaction of the triglyceride-rich lipoproteins with leukocytes and uptake of fatty acids, which leads to pro-inflammatory and pro-atherogenic state and generation of oxidative stress, which is the beginning of atherosclerosis. Postprandial lipemia is also known even in pre-diabetes state, and it's also seen in people with microvascular disease. There have been elegant studies in India by Dr. Kumar and Dr. Madhu, and also by Lokhande, that they have shown that the fasting as well as postprandial lipids have been parallel, but postprandial lipid has been coincided with atherosclerosis. Then the effect of food as well as the other aspects. If you take protein along with the milk which has fat, then there is going to be a decreased amount of amylo-like proteins. Similarly, if the proteins are added to any fatty meal, there will be increased supply of L-arginine, and there is an effect what is called insulinotropy that will improve the insulin secretions. Similarly, on the fact contrary, if the proteins index are less, then there is going to be an increased concentration of postprandial chylomicron. Even glycemic index has also been studied, and food with high as well as low glycemic index have been studied, and it has been observed that those who consume more high glycemic index food have more ApoB 100 as well as ApoB 48. And exercise has been conclusively proved to have beneficial effect by way of decreased postprandial lipemia, and anything from 11 to 20 hours before the food, if somebody does exercise, it helps. Then effect of drugs, the atorvastatin versus atorvastatin acetamide. I will not wonder if the acetamide come back again because of its effect on the postprandial lipemia and chylomicronemia. And omega-3 fat is a controversial subject. There is no clarity as far as meta-analysis are concerned, but definitely it reduces triglyceride biosynthesis and activates lipoprotein lipase. And metformin, now there is a rule, has been a finding that immediate versus sustained release. The immediate release does reduces the postprandial lipemia, which the sustained release or the extended release preparations do not. The GLP-1 analogs as well as gliptins, both have an additional effect. We know that they increase the insulin as well as decrease the glucagon, but they also have decreased production of apolipoproteins and decreased triglyceride synthesis as well as decreased intestinal lymph flow. All the drugs in this category, whether it is GLP-1 analog or gliptins, have been studied and have shown to have favorable results on the postprandial lipids. Though, what is the therapeutic perspective out of our learning about the postprandial lipemia with atherosclerosis? We must try to keep our patients to engage in physical exercise. Tobacco as well as alcohol are known to affect the postprandial lipids adversely. We must suggest for an increased protein intake, with the caveats that people with CKD or advanced nephropathy may not be given the same advice. They must restrict carbohydrate and fat diet. It's neither too fat or too carbohydrates are important, and Even if they have to consume carbohydrate, it has to be complex carbohydrate and not simple sugars. And when we select a drug, we should select a drug which has an effect in the postprandial lipids. What's the future? We have to await the results of ongoing trials about the gliptins. Morning only Dr. Sasank also said that we are awaiting eagerly about the TAPOS trial, which will be probably first time declared in the ADA June 2015. Then there is another GLP-1 analog, lixisenatide, which is yet to begin. But these are all the trials which have included postprandial lipids as one of the enrollment category, and the omega-3 fatty acid studies like REDUCE-IT and STRENGTH are also in pipeline. And there is a new branch of nutritional pharmaceutical that is called nutrigenomics, in which there is an effect of food as well as food constituents on the gene expression, and personalized nutrition based on genotype identifying characterize gene variations and postprandial responses. Maybe next time we have to go to the mall or to the pharmacist to get our food also directly. And our goal is to have personalized nutrition or individualized nutrition. So to sum up, most of us spend 2/3 of our time in the prandial state. Fasting lipid profile just do not reflect the true atherogenic profile unless we do only non-HDL. Apolipoproteins are atherogenic, and lipotoxicity and insulin resistance are linked to postprandial lipemia. We have to assess the roles of diets, drugs, exercise, and advise accordingly. Newer trials are incorporating postprandial lipid parameters, and their results will clarify the picture. Nutrigenomics with personalized nutrition definitely holds the promise. Thank you.